Hello, everyone, and welcome to today's webinar, Using Electromagnetic Energy to Improve Physical Therapy and Rehabilitative Therapy Care. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You may have joined the presentation listening using your computer speaker system by default. If you'd prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You're going to have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You can send in your question at any time during the presentation. We'll address them at the end. I would now like to introduce Dr. Tiziano Marovino. He is a doctor of physical therapy, holds graduate degrees in epidemiology, biostatistics, and clinical kinesiology, and is Chief of Health Strategy and Innovation at the Biogenesis Group, a disease management and senior human performance research center in Ypsilanti, Michigan. He performs clinical research in the areas of health economics, outcome measurement, and population health. He is an adjunct faculty member at several colleges, including the College of St. Scholastica in Duluth, Minnesota, where he teaches differential screening in the DPT program. He also teaches infectious diseases, epidemiology, and biostatistics at other colleges and completing a research PhD in exercise science at Concordia University. Dr. Marovino is an executive advisor to the journal Practical Pain Management and serves as their pain device. Take it away, doctor.
Thank you, Nikki. First, I want to thank everybody for attending. I know you guys all have other things to do, so I really appreciate that you took the time to come and listen. I will try not to disappoint. So again, my name is Tiziano. I'm a physical therapist here in Ypsilanti, Michigan. I'm cross-trained in epidemiology. My special interest has been clinical research for many, many years. So really I teach, I practice, and I conduct investigations ranging from very casual product evaluations to proof of concept, beta testing, and some clinical trials. I work at a facility called Biogenesis Group, where we focus on population health, health economic research on outcomes, and reliability studies. So my trick today is going to be coordinating my mouth and my hand here for this PowerPoint. Forgive me if I'm a little inexperienced at this. So the objectives for today, we're really going to want to focus on a discussion on Provant, on pulse electromagnetic fields, and special emphasis on Provant, of course. What it is, what it does, how it can help your patients, and how we have tested this technology at our particular facility. And we're going to spend some time later on addressing some of the evidence issues that seem to be pervasive when I've given these talks before and how they relate to clinical decision making. So from a historical perspective, if you don't like electromedicine, then this is the guy you want to email, because he's pretty much responsible for, or is known as the father of electromedicine. It's Trebonius Largus. And by all accounts, they suggest that he used electric eels and torpedo fish to cure such things as gout and foot and ankle pain. So I'm thinking he's probably the father of podiatry as well. So this is where an emoji would come in for all my podiatry buddies. But electromedicine has really evolved into something much larger and is now part of that whole regenerative treatment movement around the globe. So old versus newer forms of pulse electromagnetic fields, you know, essentially they're the same thing, but the newer version has obviously more bells and whistles. It's more specific. The waveform and energetics in particular have been refined, and there is much better shielding. And I mention this latter point because, at least in our facility, oftentimes we have patients getting a Provant treatment, and they are adjacent to other patients who have implants, whether they are paced or spinal cord stimulators. So it's important that these devices are constructed well. So pulse electromagnetic fields, what are they? This form of energy is really part of the electromagnetic spectrum, and it's similar to radio or shortwave. And a lot of our, especially our foreign trained physical therapists are very familiar with shortwave diathermy. So it's very similar. However, some special features, important points to note, the radiation is non-ionizing, so there is no cell damage. It's non-thermal, which is important for us because we can now use it on implants, prosthetics, total hips, total knees, total shoulders, total ankles, what have you. It's low energy, so it doesn't overwhelm the tissue. And the important thing to note is for Provant at least, and again, we'll get into this a little bit later, the particular energetics and waveform are very proprietary, and that's going to be important as we see in a few slides from now. So the energetics for Provant. So number one is it is a patented waveform. The FDA has approved this device for post-operative pain. The FCC has assigned a specific frequency, the bandwidth of around 27 megahertz for this device and other devices that are similar. And this frequency range really represents the higher end of the low frequency spectrum. Lower frequency devices typically are used for bone stimulation. The higher frequency devices more for pain and swelling. The specific waveform characteristics of this device, the Provant, and these are unique to Provant. It has a 42 microsecond pulse, which is really the pulse width, and it's delivered at a rate of about 1,000 pulses per second. The emission is dome-shaped, and it's depicted there in the lower right-hand side of the slide. And this becomes important when you're applying the actual electromagnetic pad on a patient. And a typical protocol that has been established historically has been 2 30-minute treatments daily. For those interested at this facility, because we are a research facility, we have taken some of those protocols and modified them and explored changing those protocols, and we've had some success. So again, if you're interested, you might want to ask me about that later on. In an acute setting, hospital, healthcare system, the Provant can be used to prevent pain chronification or chronic pain syndrome, and this has become very important. So early pain management is critical to really mitigate the chronification process. Persistent pain, as we know, can lead to both peripheral and central nerve sensitization due to the neuroplastic changes in the CNS. So if we can avoid these, bonus, that's going to be one of our goals as clinicians. In a chronic pain setting, which is really the setting that I work in, the goal is to mitigate chronic pain symptoms. So we use the Provant more as an adjunct to other techniques and interventions. We use a healthy dosing of neuroscience applications, which are cognitive behavioral approaches, and deal with some of the issues that many chronic pain patients have, along with not only the nociceptive part of the problem, but also such things as fear avoidance, kinesiophobia, and this patient population has a tendency to catastrophize. So those all need to be included in a treatment regime as well. So if we can avoid using narcotic analgesics and substitute other forms of pain management, we're going to have fewer adverse reactions, including drug dependency. And so really, in a nutshell, that's the importance, I think, of Provant in an acute setting. Now, for those of us that have used Provant and pulse electromagnetic fields in general, we know that positioning is very important, and positioning determines the actual exposure to the target tissue. So what I have shown here is the Provant pad being placed both under a knee, and in this patient, he had a total knee done as well as a ruptured patellar tendon. So lots of extensive work on that particular knee. If you put the pad under the knee, we use it to treat conditions such as a Baker's cyst, semimembranosus bursitis, ACL, PCL. We prefer the posterior application. The medial knee application we use for MCL or medial collateral ligament sprains. We use it for any kind of problem with the pes complex, which includes sartorius, gracilis, semitendinosus, and I have a slide coming up showing the anatomical depiction of those. So positioning is critical. And as promised, here is the actual pes anserinus. So by putting the Provant pad medially, we really cast a very wide net and can expose a lot of tissues that become problematic, especially in my population, which tends to be older folks. Although we have some athletes and sports medicine cases, the vast majority of my demographic is 50 and older. So the lateral and frontal views or a pad placement. We use the lateral approach for our IT band and our lateral collateral ligament patients. And we use the frontal placement for patellofemoral syndromes, for patellar fractures, chondral lesions, chondromalacia, that sort of thing. So evidence. Well, there's nothing more controversial at stimulating discussions, I think, than evidence and what it means to the individual. And everyone uses this term, but no one ever seems to define exactly what it means to them. And clearly, at least when I give presentations, it is quite clear that everybody has their own rationale and critical threshold for evidence, and the kind of evidence that is important for them that they need to help support a treatment. And another question I think comes to mind, does the absence of evidence suggest evidence of absence? Do we only use interventions that are well researched, or do we use interventions that we have experienced as effective? And I would suggest to you that it is the latter. So in this case, we have both well-researched device in Provant and along with considerable empirical or observational evidence. And evidence-based medicine was proposed by David Sackett in around 1991. And when he described it in, I believe it appeared in the Canadian Family Physician, and I worked with Dr. Sackett at McMaster University. It was one of my first research studies. And I think if I remember correctly, it had to do with inhibitive casting, a term that I used back then, and I don't think I've run into in the next 30 years. But so I had the honor and the privilege of working with Dr. Sackett on one of his research teams. And he was about the triad. It wasn't just about randomized clinical trials. It was about the patient. It was about the provider. It was about the intervention and the information that we can derive from all three sources combined. And that's how we provide an optimal experience for the patient. So randomized clinical trials are very useful, and their usefulness is not stopped. However, there's also the limited generalizability of randomized clinical trials because they generally answer a very specific question, a very narrow one. They are costly and they're time consuming. So not every question, not every research question, I would argue, needs to be or can be answered using a randomized clinical trial design. What we focus on here at this facility are outcomes or patient endpoints. So outcomes are those endpoints that we deem to be important and intend to measure in a study. We choose our endpoints that are important to us as researchers, and I inevitably always get a question, what outcomes do I need to choose? And my answer is always the same. You choose the endpoints that are important to you. You choose the endpoints that you value. There are many different types of outcome measures: clinical measures, functional measures, condition-specific measures, lots of different types of outcomes. And so, again, you choose those that are important for you. We at this facility like to use functional measures because of the nature of who we are and what we do. So we're physical therapy based, physical therapy and rehab medicine. So these measures are also tied into our reimbursements. We like to use SOMs, or standardized outcome measures, sometimes referred to as patient-reported outcome measures. They are self-report instruments, and they provide patient perspective on what is important. And I would again argue this aspect has been lacking for too long in the pharma model using randomized clinical trials. I think that's a nice model to determine which drug works the best, not so good at identifying which patients respond to that drug the best. I thought I'd include some of the more recent research that has been sparked by the use of pulse electromagnetic fields. So a novel outcome measure is using diagnostic ultrasound imaging to quantify the relationship between an exposure, PEMF, and an outcome, which is hyaline cartilage regeneration. I think this is probably going to be something we will be embarking on here at this facility. We have been doing diagnostic ultrasonography since 1997, so it's in our wheelhouse, and it's something that we're interested in doing. In the meantime, other groups around the globe have been doing it for the last 4 or 5 years. I have a whole list of references in the back for those who are interested in exploring that a little bit more. Another rather novel, I feel like I'm complimenting myself. It's not the way I mean to sound, but this is another outcome measure that is not commonly used for some of our rehab interventions. But I thought it was important because for so many devices that we get in, when we're asking the manufacturer, what's your value proposition? How does this work? They inevitably will, talk about perfusion and saturation. So we happened to test some biosensor technology a few years back that would help us kind of elucidate and better understand that. So we use biosensor technology now routinely to test out our devices. And so we applied oxygen biosensor technology, pre and post Provant, to selected patients, ranging from, literally, we had some world caliber runners come in because they come in, I get for diagnostic ultrasound scanning. I'm the ultrasonographer for USA Running, so we get a lot of these guys coming in. We took some of those, but then we also used some of our in-house patients, very deconditioned, obese, diabetic, lots of comorbidity, some of those patients. And what a difference in oxygenation just with one single 30-minute pulsed EMF treatment, one Provant treatment, pre and post O2 measures. So clearly the Provant is having an effect on oxygenation and hemoglobin levels. Another important population that I see that can handcuff us at times in terms of treatment interventions will be our neuropathy patients, our diabetic neuropathy, our all the different neuropathy subtypes that are out there. And so we really felt that our neuropathy patients could benefit from improved perfusion that we were seeing with this biosensor technology. So we began testing them using various instruments, including pressure analysis. And that's what you're seeing here on the right-hand side of the screen, the 3D dynamic motion analysis. It captures very subtle shifts in pressure, and it's a nice tool to have to help quantify balance when we have sort of bilateral, people are standing on this pad with both feet. We can begin to see if they have areas of pressure as well as areas of pain, because typically the areas of pain have lower pressure. So we have measured improvements pre and post Provant interventions, typically 4 to 6 weeks. It does take some time, and these guys are usually on a 3 times a week single treatment regimen. So again, we deviated a little bit from the Regenesis protocol, but part of what we do is explore all the different combinations, permutations, if you will. So the next few slides are going to focus on some of the key research that has been done. I thought this was appropriate because it was done at the VA, and we just wanted to draw your attention to these different publications that you might be interested in as an audience. This one by Merpuri was published, I believe, in 2015. And they used an open label retrospective chart review of 40 VA patients and reported a very significant pain intensity reduction over 8 weeks from 7.9 to 3.0. And this is significant at the 0.001 level. So there's less than 1 in 1,000 likelihood of these findings occurring by chance. So another retrospective study compared narcotic analgesic refill rates in a post-op rotator cuff group, and there were 36, I believe, and they were receiving Provant versus a similar sized group not receiving Provant, and that sample group was 37. So they were evenly matched in terms of numbers. The Provant treated group refilled at a rate of 69%. So 31% did not refill their opioid prescription. The no Provant control group, if you will, refilled at a rate of 86%. So 14% of them did not. So pretty significant difference in the need to refill for pain medicine. Another study, this one was randomized, sham-controlled, and double-blinded by Sorrell et al., published in 2018, compared three groups, and again, including a sham, and that's important, I think. So there was a sham group, a 42 microsecond, again, that pulse width group, so the 42 group, and a 38 microsecond pulse group. And you're probably wondering, okay, why? Well, this is going to be important in a slide or two. Let me get back to that. So again, a sham, a 42 and a 38 microsecond group. So the researchers tweaked the energetics a little bit just to see if energetics were important. So at 60 days, there was a significant decrease in both back and leg pain, because they're tracking both as outcomes, in the 42 microsecond exposed group relative to the sham by about 40% for the low back pain and about 45% for the leg pain. So pretty significant. And then further to that same study, if you ever get a hold of this study, you're going to see they used just a ton of outcomes. I couldn't possibly report them all, but another one of the outcomes I thought was very clever to use because it's important, and that is one of the inflammatory biomarkers, a very common one, CRP or C-reactive protein. That was, they looked at the levels of that as well, and they found that the 42 microsecond exposed Provant group compared to the 38, well, in the 42 microsecond, the CRP levels actually decreased. And an interesting occurrence at the 38 microsecond, where we have a very significant increase of these inflammatory biomarkers. Not sure why, by the way. Okay. So clearly there are two primary pathways for Provant in terms of mechanism of action. And this slide describes both of them. The first one is through PEMF, or Provant exposure, will provide an anti-inflammatory effect, as well as decreasing the pro-inflammatory molecule. So it's really kind of a twofold anti-inflammatory effect. And really both will act to reduce inflammation. I think interesting to note again in that Sorrell study that I just showed, how the tweaking the energetics from 42 to 38 microsecond caused such a dramatic difference in terms of the CRP, or the inflammatory biomarker. So at 42 it decreased, at 38 it increased significantly. That second pathway is one that is a little bit more familiar to some of us who practice in pain medicine, and that is the induction of endogenous opioids from stimulation of free nerve endings. I also do acupuncture, so as an acupuncturist, I'm really more familiar with this mechanism of action. But I got to tell you, as a clinician that treats a lot of inflammatory conditions, it's nice to have a treatment tool that can approach a problem in several different perspectives or directions. So I guess the lesson here is that, energetics are important. They really do matter. And how the waveform is constructed, how it's delivered, how it's engineered. I thought about it the last couple of weeks as I was preparing for this presentation, and kind of combined some of the research out there with my personal experience. And it really is, the energetics of Provant is I'm going to call it their secret sauce, not to steal from McDonald's, but it clearly is a secret sauce. The energetics is what defines this device, and I think is responsible for the unique benefits that we see as a facility when we use this device. But I don't think that's unique to Provant. I think these energetics will, in effect, define the effectiveness of virtually any electrotherapy device out there. So it applies to all the devices. So patient satisfaction. I think this is important to talk about as well. So patient satisfaction levels have really been put to a premium these days in many different ways. And it's really all about the patient perspective, since ultimately they're the ones that are going to decide whether or not to return for a treatment, whether they see value in a treatment, and whether they're going to return to your facility. So gauging satisfaction levels is critical to doing business in healthcare, period. So this last slide really depicts satisfaction levels for the device, the company, the user friendliness, and the equivalent, I guess, of a net promoter score. That last bar graph would recommend Provant therapy to others. All of those areas ranked very, very high, and I think that's important. And all these reasons are why I have consistently ranked this technology at the top of the must-have devices in the treatment of pain when I'm asked to write up those issues for the different pain journals. Alrighty, so the last two slides really are about references, and thank you all for listening. I hope you've enjoyed the presentation. I hope I haven't gone through this too fast. I was worried about really being long-winded and and going above my hours, so I may have overcompensated a little bit. I apologize. But let's get into some questions and answers, and I think this is really the most important part of the presentation anyway.
All right, great. Well, thank you, Doctor. We're now going to begin answering the questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Our first question is, thank you for an informative presentation. Please share with us more about your patient population, such as how you identify responders to Provant therapy.
Oh, I would hire that person. Who asked those questions? Awesome, very good. Both great questions. All right, one at a time. Who is my patient population? My patient population is, I want to say chronic pain patients, but I'm very, very careful. My definition of chronic pain syndrome patients is a patient who has depression, drug dependency, and deconditioning. That's a definition that I believe was coined by a couple of psychologists in Greenville, South Carolina, David Tallis and Mike Kriegel, who I trained with. And I've always used that, but not all of my patients fit that. I get patients that sometimes I think are misdiagnosed. I get patients, so all my patients have one thing in common, they have persistent pain. Some of them I think are misdiagnosed, some of them, and very typical, in my opinion, the differences between lower spine pain and sacroiliac joint pain. I have patients who have been medically mismanaged, simply given medicine. So not everyone is a chronic pain patient. Chronologically, they are, but I think they come from different sources and there are different subtypes. So I think I get a nice smattering. Every once in a while, I do get a classic chronic pain syndrome. And so really, does my center differ that much from an outpatient or a hospital-based orthopedic PT center? Probably not. Oh, and I'm sorry, there was a second part to the responders. Beautiful, beautiful. For years, I have been pleading and advocating. Providers, we need to do a better job at selecting our patients. Well, how do we do that? Well, it's not hard. You try something on someone and watch the reaction, gauge it, measure it, however you do it. We have to be able to select who responds to a treatment. Now, it's interesting that it's the research people that have caught on to this. If you read studies now, you'll see there is the main analysis, and then, lo and behold, you've got the responder analysis. A lot of times that responder analysis is because the main analysis didn't quite work out, but they recognize, if you comb through the data, if you look at the raw data, you got a lot of people that responded very well. So if you pull those out of the main analysis, lump them, put them together as a group, now you've got something. I would argue we have to do that clinically, not just in research. But the fact that the researchers are now okay with that, in the old days, we used to call that data dredging. Now it has become a very elegant technique statistically, so it's done all the time. And so responders, again, my definition here of a responder, and you can have your own, mine here, I will try the Provant 2 times. If I get nothing or next to nothing, if I can't measure impact, then to me that is a non-responder. Knowing full well that we have slow responders, if I had taken more time and maybe tried it for a week or 2 or 3, I might have gotten something. So it's kind of like cut points. You have to decide what your cut point is, and we've chosen 2 sessions as a cut point here.
Okay, great. And someone's asking, can this therapy reduce low back arthritis pain?
Yes, I have found that this treatment does not work well when there is not an inflammatory component, or should I say, it works much better when I have high inflammation. So I remember making that comment, and one of the PTs put up their hand and said, well, then it has no place here because I just see primarily mechanical type problems. So stop. Now, wait a minute. Even in mechanical type problems, I treat those as well all day long. There is usually, especially if it's an acute on chronic, an inflammatory component. And I never try to guess that anyway. It doesn't take me much time just to put someone on a Provant, and I let the treatment effect decide whether there's inflammation or not. I have no special tool to identify that. So for this person's question, if there's high inflammation, you're going to love it. If there's very low inflammation, then maybe not so much.
All right, thank you. And then, is the Provant therapy available through Medicare?
All right, now that Nikki, that's really outside of uh, my bounds. I'm not really sure. Is the person asking, is there is reimbursement for not necessarily Provant, but all pulse electromagnetic fields via Medicare? So Medicare has a code. They do have a payable code for it, not specific to Provant, but for pulse electromagnetic fields.
Okay, great. Another question, with chronic pain patient, do I request a unit to try to ease his pain on pain pump and oxycodone? How would one get a unit?
Yes, this is where I think uh, probably Scott would be answering these because mine is really more the clinical presentation. I have Provant as a research facility, so I'm not really sure how to address it, other than I think I would defer it to a Provant rep, and I know they're all over the country. Can we, whoever asked that question, Nikki, can we just give them the contact
Yeah,
information?
Scott can definitely follow up afterwards. And I believe Scott was
Yes,
saying it's available through Veteran Affairs, but not Medicare reimbursed yet. But yeah, any step that can't get fully answered, they can get followed up on.
got it. Well, further to the Medicare, we have built up for Provant under shortwave diathermy, which is what essentially the category that it would be placed in. And so there was some reimbursement. So again, not Provant specific, but for a shortwave diathermy, there is reimbursement.
Okay, perfect. Someone's asking, what measure do you think is more important, pain reduction versus functional improvement, or ROM?
Oh, well, that what they're really asking is, are you really a physical therapist? What are you exactly? So yes, I like to use, I'm not crazy about pain scores. I don't think they tell me much. I like pain interference scales and scores because they give me a pain score within the context of function. At the end of the day, I will always be a physical therapist. I'm all about function. There is nothing more important than function, but sometimes, and the reason why I kind of broke away from mainstream PT in this area and started a pain clinic is 15 to 20% of the folks that we see will not respond to traditional, PT approaches. Sometimes you really do have to focus on the pain. So my approach here is that's what I do. I focus on the pain, but I let them know the idea is to get it to improve your function. I'm just going to do it a little bit differently. In years past, I would have started with the exercise and tried to push and push and push. That's where the reimbursement is. That's where my tenure is for whatever employer I work at. Now I'm older. I don't worry so much about those things. I just try and do what I think is right. I take the approach that works for me. And so for the first little while, I will focus on pain. So function is the ultimate goal.
Perfect. Okay. Next question. Could this be used for chronic rectal pain issues?
Okay, so I have, and I'm thinking back because I just sent a patient up the street. We have, I refer to her as a women's health therapist, but probably not correct. Forgive me if it's an old term, but they will deal with those kind of issues. And I can tell you that as long as I'm comfortable that this person that you're describing has been medically screened, and I don't feel that it's anything visceral, so we're not getting any kind of visceral somatic convergence here, then I personally, I am not going to recommend that that person do it, but I would probably try it here. And we have tried it on mystery pains. I remember a gal that we had who had intractable chronic pelvic pain, but I cleared it with her primary care physician first. So could it help? Again, if there's inflammation, yes, but I think we always have to be careful that we as physical therapists are not masking problems that are a little bit more serious. And if this person is a little bit older, I would want to make sure that the primary care physician is part of the decision making on that.
Okay, great. Thank you, doctor. So looks like we do have another question. What is your typical patient reaction to their outcomes with Provant treatments?
Well, as I was preparing for this, and about, I'd say halfway through this presentation, I had a gentleman, a patient on Provant, and I couldn't talk to him. Obviously, I was talking to you guys, but I got the big thumbs up. And I think what he was trying to tell me was his ankle was feeling really good because he could barely walk in here. And he kind of shrugged his shoulder, like, what does this thing do? So I had him on the Provant, but that's the typical reaction. The Provant, quite honestly, just makes me look better than I am because I just get outcomes that that are just stellar in many cases, and not in all cases, of course. You know, no therapy works for everybody, and I still have all the other treatment brands out there. And, you know, part of my job is trying to figure out which technology, which energy works for what condition. So, you know, a typical response, again, because I've already filtered my patients, i.e. I have selected them. I spend a fair bit of time in trying to select the right patients. That's going to up the ante for me in terms of my outcomes. I'm going to have good outcomes. Whereas if you're going to put the Provant on everybody without screening, then you have to expect that overall your outcomes, if you pool everything together, are going to be a little bit less. So I just think selection is a big part of it.
All right, great. Well, I don't see any other questions coming through, so that was our last question. Any final thoughts, doctor, before we end?
Well, I hope, you know, these presentations to me are not presentations where I come into this trying to sell anything. I'm not trying to convince you of anything. I would only make the plea, as I do to all my local therapists around here that visit me from time to time, if you get a chance, just try it. You can read about the research, but bottom line is I've had devices come through this door and they come with a ton of research, but it doesn't deliver. So the research doesn't sell me on anything. I mentioned the research, so it can give you kind of a head start. This is not a nascent technology. It is well researched, relatively well researched from different perspectives. But at the end of the day, the most important thing is that you guys get a chance to try it. If you contact the company, I'm quite sure they will let you try one. I call them yellow boxes, and just see for yourself.
All right, great. Well, thank you everyone for attending, and thank you, Dr. Marovino. I hope you all have a great rest of your week.
Thank you.